And we are particularly pleased today to welcome back one of our own, Carlton Haywood Jr. Carlton is a double who, with a BA in Religious Studies from the college and an MA in Bioethics from our center. He then went on to receive his PhD in Bioethics and Health Policy from Johns Hopkins, where he's now in the faculty in the Department of Medicine and in the Berman Institute of Bioethics. Dr. Haywood's here to talk to us today about a subject he knows intimately, Sickle Cell Disease, a disorder that was first described 100 years ago in 1910. It's good for us to note, I think, that the second description of that disease, which was in 1911, was a description. Both of those articles, by the way, 1910 and 1911, are in the bibliography on your handout. The second description was of a patient here at UVA, and the reporter, Mr. Washburn, as you see in the article, was then a UVA medical student who had first noted these peculiar, elongated, sickled red cells in his patient's blood. And we in medicine ever since have found the clinical pathology and the genetics and the demographic patterns of this disease fascinating. But we've also found, if we've been paying attention, that there's perhaps no other disease on the books in which our clinical and scientific observations and assumptions so sharply come up against our and our society's prejudices about race, plus our equally firm clinical prejudices concerning what we think we know about pain management and addiction, and especially in their relation to race and culture. During the years in which I was an attending physician in pediatrics at a medical center about 500 miles south of us, almost 50% of the children on my service were admitted with a diagnosis of sickle cell disease plus something. Sickle cell disease and fever or sepsis or pain crises, or less commonly stroke or sequestration syndrome. The children who sometimes called their affliction sick as hell anemia knew precisely what they were talking about. And issues of trust abounded then, as they do now, from the memorable patient who showed up over and over with every pain twinge because, for very good reasons, he did not trust his mother to respond appropriately to his needs, to the many patients who didn't show up until they were critically ill because, again, for very good reasons, they didn't trust us to respond appropriately to their needs. This was also a time when various policy proposals for widespread screening for homozygous disease, and particularly for the heterozygous trait, were being put forward and were being shot down by African Americans who saw them as being nothing less than thinly disguised genocide. This year, the NCAA has put forth a ruling that college athletes must be screened because of observations of the health effects of sickle cell trait. At 3:30 this afternoon, Dr. Haywood is going to be discussing that issue about screening for sickle cell, and particularly in the light of the NCAA ruling, at a seminar in Gibson 211, 3:30, to which you are all invited. But all of these things and more have captured the attention of Carlton Haywood, and we're very grateful that you can be here today to offer your wisdom on the topic. We're also grateful to the Institute of Practical Ethics and Public Life and to the library's History to Health Sciences series for co-sponsoring this with us. Responding to Dr. Haywood is Dr. Pamela Ross of our Department of Emergency Medicine, who will, I assume, be speaking from her experience as both a clinician and an advocate for the patients who come to her for care. And then, of course, time permitting, we will take your questions and comments at the end. Carlton, welcome. Have at it.
Good afternoon, everyone. Can you all hear me okay? Yep. All right, great. So it is truly a pleasure and an honor for me to be back at my home, University of Virginia, to talk to you all today about topics which I do have not just professional but also personal interests in because of my own status as someone living with sickle cell anemia. And so I want to thank all the sponsors and co-sponsors of this event, and thank you all for your time in coming today as you helped me commemorate 100 years of sickle cell disease in this country. And I have a lot that I want to try to get through and still leave time for discussion. So with that, let us begin. And I want to start out with, a quote. Have you ever heard of a disease known as sickle cell anemia? Most people have not. Yet sickle cell anemia is one of the more common and one of the most serious of all childhood diseases. The lack of attention that's been given to this disease is truly a national disgrace. These words were spoken in 1970 at the beginning of a media campaign that was to be launched to raise awareness about sickle cell disease. And unfortunately, for those of us who live and work in the sickle cell community today, these words still ring true some 40 years later. Which leads to my objectives for today, which really, at its core, I want to help raise awareness about sickle cell disease in this country. I want to do this by reviewing its so-called origins in this country, the impact it has on the affected individual, or a little Sickle Cell 101, and I want to examine 3 chapters of our history with sickle cell disease that continue to challenge clinicians, policymakers, and the affected community today. So let's begin with the origins of sickle cell disease in the U.S. In 1904, a young man by the name of Walter Clement Noel was visiting Chicago from Grenada to attend dental school. One day he presented to a private hospital in Chicago complaining of respiratory difficulties and joint pain. His physicians, Drs. Ernest Irons and James Herrick, cared for Mr. Noel, but they were unable to identify the specific cause of his illness. However, they did identify a strange characteristic to Mr. Noel's blood. And this is the now classic description that it provided of the sickle cells that were in his blood. And you see these odd-shaped blood cells in this blood sample. Now, from 1904 to 1907, Drs. Iron and Herrick continued to provide care to Mr. Noel as needed. But eventually, he finished his training and returned to his home country. Still, from 1907 to 1910, Drs. Irons and Herrick continued to search for a cause of Mr. Noel's condition, but to no avail. Finally, Dr. Herrick published the patient's case history, and this is his first case report of sickle cell disease. Peculiar, elongated, and sickle-shaped red blood corpuscles in the case of severe anemia. And this case report is recognized as the first clinical description of sickle cell in Western medicine. I think it's important for me to stress the Western medicine part because we actually know from examining African narratives and African literature that you will find descriptions of sickle cell disease that predate 1910. But it is with this case report that first puts sickle cell disease on the map of Western biomedicine. And as Dr. Norman pointed out, UVA has its own special history in the history of sickle cell disease, as it was a UVA medical student that published the second case report of sickle cell disease. In February 1911, Benjamin Washburn was a fourth-year medical student here at UVA, published his second case report. And the patient, Miss Ellen Anthony, she frequently received charity care from the UVA hospital from 1907 through 1918. Now, with this thought of origins in mind, let's take a step back and do a little Sickle Cell 101 for those of you who are not quite as familiar with the disease. Now, as many of you know, sickle cell disease is considered the first molecular disease. That is, sickle cell disease is the first human disease which was understood to have a molecular basis. And it's through this understanding and this study of sickle cell disease that really opened the doors to molecular biology and genetics as we know them today. Now, what is sickle cell disease? Well, sickle cell actually refers to a collection of genetic conditions which affect the hemoglobin within red blood cells. Now, hemoglobin is that substance which, among other things, gives red blood cells their color and transports oxygen and carbon dioxide to and from the tissues in the body. And if you can see, if you can make out, here is just a cutaway view of a blood vessel, and inside the blood vessel you see the red blood cells. And then inside your red blood cell, you have, among other things, you have these hemoglobin molecules. And it's this hemoglobin molecule that binds onto oxygen and allows the red blood cell to carry the oxygen throughout the body. Now this normal hemoglobin is referred to as hemoglobin A, okay? Now, if you're like me and you're born with sickle cell disease, we have a different type of hemoglobin. It's called hemoglobin S. Our hemoglobin, it begins in the same shape as the hemoglobin A. However, under certain conditions, our hemoglobin actually changes shape, and it goes from being this ball-like structure to forming these chain-like, polymer-like structures. And as the blood cell is full of these hemoglobin molecules, you can imagine that when these sickled hemoglobins undergo their change in shape, it causes the entire red blood cell to change shape as well. The normal red blood cell is a round, malleable, kind of donut shape. One of my colleagues describes it as this. He says, think of the normal red blood cell as a water balloon. With a water balloon, you can squeeze it and deform it into a variety of shapes up to a certain extent, and it'll regain its original form. Now, think of the sickled red blood cells as a water balloon that's been frozen overnight, and it's stuck in some weird shape. It no longer has the ability to be deformed. It loses that malleability that the normal red blood cell has. And so you might imagine then what happens inside the blood vessels of persons with sickle cell disease. When the red blood cell goes through that sickling process, you can see that what can happen is it causes these little tiny clots, which we call vaso-occlusive events. And this is a simplified view of the pathophysiology of sickle cell disease, but I think it helps to imagine what might be going on. And when you have these vaso-occlusive events, what happens is it cuts off the flow of blood and oxygen to whatever tissues are being fed by those blood vessels. And we then, as a person with sickle cell disease, experience that in a number of ways, particularly as episodes of pain, that I'll talk about in a few minutes. Now, globally, we estimate that between 5 and 7% of the world's population carries a gene for a hemoglobin disorder, of which sickle cell disease is one of the more common. And we estimate that between 260 and 300,000 babies are born each year across the world with some form of sickle cell disease. Actually, sickle cell disease has been designated as a priority health condition by both the World Health Organization and the United Nations. They both claim that as a global community, we need to pay more attention to sickle cell disease. Here in the US, sickle cell disease is found between 1 out of every 2,500 and 1 out of every 2,000 newborns born in the US, actually making it the most common condition detected by newborn screening efforts in this country. African Americans have the highest birth prevalence, which is about 1 out of every 400 African American births that has some form of sickle cell disease, and is present in smaller numbers in both Hispanic births and in births from groups of other racial and ethnic populations, and we'll talk about that more in a minute as well. Overall, we estimate that about 100,000 persons in the U.S. have some form of sickle cell disease. Now, I want to stress here the estimate part, because unfortunately, our public health surveillance for sickle cell disease in this country is really not all that good, and we're just making our best guesses as to total numbers. You can pick up a literature and see numbers ranging from 50,000 sickle cell patients to 70,000 to 100,000. Right now, the 100,000 figure is the figure that's in vogue. Now, what does sickle cell disease actually do to you? Well, among other things, persons with sickle cell disease are more susceptible to infections. We can experience significant health complications in life, including strokes, cognitive impairments, renal disease, lung disease, bone necrosis. I mean, think about it. Sickle cell disease, as a disease of the blood, it can affect potentially every part of the body. And unfortunately, persons with sickle cell disease experience early mortality. We currently estimate that the life expectancy for males with sickle cell anemia, which is the most common and most severe form of the disease, is about 42 years. And for women with sickle cell anemia, we estimate median life expectancy is 48 years. Now, as serious as these complications are, the most well-known symptom of sickle cell disease are the episodes of acute pain that it causes, which are referred to as sickle cell pain crises or sickle cell crises. Treatment for acute pain is the reason behind the majority of emergency department and inpatient hospital utilization by sickle cell patients. Now, for a long time, it was thought that sickle cell disease was an acute pain syndrome. That is, if the patient was not in acute pain, they must be okay. But recently, we're beginning to understand that sickle cell disease should be thought of as a chronic pain syndrome as well. As some authors have recently proposed, Dr. Smith et al., they propose we think of sickle cell pain as using an iceberg model. So they conducted a study where they collected about 30,000 days worth of diary entries from adults with sickle cell disease. And among other things, they wanted the sickle cell patients to talk about how much, did you have any pain today? If so, what level of pain was it, etc. And what they found is in these 30,000 patient days that they collected, they found that sickle cell patients reported having no pain on less than half of their days. So on 45% of their days, the patients reported having no pain. So on more than half of the days, patients reported having some type of pain. And when you look at the painful days, the top part of this bar here, on about 38% of those days, they said, well, I had pain. I wouldn't call it my sickle cell crisis pain. And it's not something that I went to the healthcare system for, so I didn't see a doctor for it, but I still had pain on that day. On 12.7% of their days, they said, well, yes, I had my sickle cell crisis pain, but I still didn't go and seek any kind of healthcare treatment for it. And on only 3.5% of their days did they say, yes, I had my sickle cell crisis pain, and yes, I sought some type of healthcare for it, either through an emergency department or an outpatient visit or an inpatient visit, which suggests that clinicians are only seeing a very small proportion of the total pain experience that sickle cell patients have. And so these authors liken it to an iceberg. With an iceberg, we only see a very small portion of the iceberg's total volume. They suggest that there's this large volume, this large body of sickle cell pain that clinicians are not really aware of. And they hypothesize that this contributes to some of the problems in healthcare quality that I'm going to talk about later in this presentation. Now, are there treatments for sickle cell disease? Well, when we do seek treatment for our pain in the hospital, we're typically given oxygen, we're given IV fluids, and we're given powerful narcotic pain medications. A drug called hydroxyurea is the only FDA-approved disease-modifying therapy available for sickle cell disease. What hydroxyurea does is it increases the amount of fetal hemoglobin that's in the body, and fetal hemoglobin is less likely to go through the sickling process. And so while it's not a cure, hydroxyurea has been shown in many patients to reduce the frequency and or severity of their sickle cell pain symptoms and attacks. Some patients often require regular blood transfusions as a way to try to manage their symptoms, manage their pain. And many people think that there's no cure for sickle cell available. That's not strictly true. There is no universal cure for sickle cell disease available. However, some patients have been cured through hematopoietic stem cell transplantation, so either through the bone marrow transplants or through umbilical cord blood stem cell transplants. It's just that these curative therapies are not at a point where they're viable as an option for the majority of sickle cell patients. Only a small portion of sickle cell patients are really viable candidates for these therapies at the present time. And now this graph here, I mentioned to you the life expectancy for persons with sickle cell anemia. And as tragic as that is, I do want to say that it is much improved from where we were not too long ago. So in this graph presented by the NIH, they show that as late as 1970, life expectancy for persons with sickle cell anemia was only in the teens. And so you see, even from then till this graph stopped in about 2000 or so, there's been great improvement. It's just that there's still this large gap between the sickle cell population and the general population. So now, we've talked about the origins. We hopefully now have a kind of basic understanding of what sickle cell disease is and what it does to you. Now I want to bring your attention to 3 chapters in our history which present policy problems for clinicians and policymakers working in sickle cell disease today. And the first chapter is the so-called racialization of sickle cell disease. So how did sickle cell disease become so linked with notions of black race? So this article was published by Dr. Vern Mason in 1922, and in it he says in part, "It is of particular interest that up to the present the malady has been seen only in the Negro, and so far as can be ascertained, it is the only disease peculiar to that race. Now, Dr. Mason writes this after only the 4th case report of sickle cell disease in medical literature. So after the 4th case report, sickle cell disease was declared a disease of the black race, okay? And even as patients with sickle cell disease who were non-black began to appear, this idea of sickle cell being a disease of the black race persisted. As Dr. Ogden writes in 1943, I have a right to my strong conviction that the sickling trait is a condition found in the Negro race only, and that in all cases in which members of white families have such a trait, an admixture of Negro blood in the immediate or occasionally the remote ancestry has taken place. So as patients with sickle cell disease began to appear who were non-black, the biomedical community had to struggle. So what does this mean? We've already declared sickle cell as a disease of the black race. So what does it mean then we're seeing non-black people with the disease? Well, what happened was that these non-black people, it's like for white families or white patients with sickle cell disease, the biomedical community viewed them as apparently white. You're not really white. You may look white, but you may look white, but you have this sickle cell disease in you, which is a sign of Negro blood. So they were deemed as apparently white individuals. And this threat of sickle cells and this link to Negro blood was thought to have public health implications. Dr. Ogden continues to write in this article, sickle cell anemia is a national public health problem here in the U.S. Intermarriages between Negroes and white persons directly endanger the white race by transmission of the sickling trait. Such intermarriages, therefore, should be prohibited by federal law. So here, sickle cell disease and its link to Negro blood had real public health implications that society was supposed to have to deal with. In addition to this threat, sickle cells were thought to be a sign of biologic inferiority. As Pettigrew et al. Write in 1963, sickle cell anemia, primarily found in Negroes, is the favorite disease exhibit of white supremacists. Though it derives from an adaptive evolutionary process, they feel the disease is ultimate proof of the innate inferiority of Negro blood. So now, in the beginning, to sum up, or to review, sickle cell disease was a disease of the Negro race alone. The presence of sickle hemoglobin was a sign of the inherent inferiority of the individual who possessed it. And this Negro blood posed a health risk to other racial groups because of the possibility of transmitting the sickle cell trait to other groups. Well, Dr. Haywood, this is all interesting history, but how does it affect us today? Well, depending upon where you live, you may have picked up a newspaper article with headlines like these. Sickle cell disease spreads. Medical centers adjust how they look for and treat the blood disease as it grows among Latinos. Or, sickle cell disease is spreading through the UK. It's one of the most under-researched diseases prevalent in the UK, and it's spreading throughout the country. Or, my favorite, painful blood disease. Sickle cell now spreading to other groups besides blacks. So here, you have this persistence of the link between sickle cell disease and black race. And you also have this, what I find, troubling imagery, troubling language of the public health implications, the risk, the threat that persons with sickle cell disease are posing to other groups. This notion of sickle cell disease and black race also affects individuals' perceptions of their own risk. This personal profile is posted on the National Sickle Cell Disease Association's website, and I'll read part of it to you. Sickle cell disease can affect any race. My name is Vicky, and my husband and I are a Caucasian couple with 2 beautiful boys. When I was pregnant, I was tested, and my doctor wanted to test my husband for it as well. I received a call several days later that he has a sickle cell trait. I said, no way. My husband has blonde hair and blue eyes. We thought at the time that this disease was only a black disease. So even today, this idea of our person's individual risk for sickle cell disease, us being affected by this link between sickle cell and black race. So now, what are some of the challenges and questions that are posed to us today, given this part of our history? Well, given the historical beliefs about sickle cell disease and its link to Negro blood, how how can or how should clinicians and public health professionals talk about risk for sickle cell disease without, one, stigmatizing those of us with the disease or with the sickle cell trait, or two, continuing to reify this notion of sickle cell disease as a black disease? And how do we balance these concerns with what my physician colleagues often tell me, but Carlton, 99% of my patients are black. So what are you trying to tell me here? So how do we balance these kind of competing thoughts, these competing imagery? Also, I think it's really interesting from a research perspective about the meaning that having this so-called black disease has for someone who is non-black. What kind of impact, if any, does it have on those individuals and those families? I think that's something that anyone interested in kind of the ethics of this issue or interested in notions of racial identity, genetic disease, this is, I think, a fertile area of research ground for the future. So now, that was part one of the history I wanted to point out to you. Part two, let's talk about health policy, sickle cell disease, and health inequities. And the question I'll pose to start this section is, has the historic characterization of sickle cell as a black disease contributed to a disrespect that is shown toward the disease in the form of inequities at the level of health policy? In 1970, Dr. Robert Scott wrote and published this now classic article in the sickle cell literature called Healthcare Priority and Sickle Cell Anemia. And what he did in this article was he compared sickle cell disease and its prevalence to that of a number of other so-called childhood diseases at the time. And he looked at the amount of funding they received from both federal and private sources. And I want to just pull out one of his comparisons for you today. So one of the comparisons he made was between sickle cell disease and cystic fibrosis, which itself is a very serious genetic condition. Now, he used data from 1967. And so he estimated that in 1967, there was about the same prevalence, about the same incidence of cystic fibrosis and sickle cell disease. About 1,200 new cases of cystic fibrosis and about 1,150 new cases of sickle cell disease. Yet when you look at the number of NIH grants for cystic fibrosis compared to sickle cell in 1967, cystic fibrosis received nearly 3 times as many, 65 grants compared to 22 grants for sickle cell disease. When you look at private support, while sickle cell was estimated to raise about $50,000 in 1967, cystic fibrosis was estimated to raise $2 million, the ratio of 40 to 1. As Senator John Tunney was quoted as saying in 1972, if sickle cell anemia afflicted white people instead of blacks, we would have made a commitment long ago to end this disease. As President Richard Nixon was quoted as saying, this disease is especially pernicious because it strikes only blacks and no one else. In February 1971, I pledged that this administration would reverse the record of neglect on this dread disease. Now today, there has certainly been progress in the attention given to sickle cell. I mentioned to you the United Nations efforts and the World Health Organization's efforts to raise priority for sickle cell disease. Actually, the United Nations, as some of you may know, has now designated June 19th of every year to be World Sickle Cell Day. So it's a day that countries across the world should try to raise awareness for sickle cell disease. It's June 19th. In addition, here in the U.S., in the past few years, there have been a number of major bits of federal legislation aimed to improve the lives of those of us with sickle cell disease. So certainly there has been progress made. And yet, there's evidence that there's much more work to be done. In 2006, Dr. Lawrence Smith et al. Published this article called Sickle Cell Disease, a Question of Equity and Quality. And what they found is, in part, was significant gaps persist in public and private support for research and clinical care. And just like Dr. Scott before them, they compared funding for sickle cell disease to that of cystic fibrosis. Now, instead of using incidence, they used prevalence. And so they estimated that, using 2004 data, they estimated that sickle cell population, the size of that population, was more than 3 times the size of the cystic fibrosis population. And yet, cystic fibrosis received about $4,300 per capita of NIH support compared to $900 for sickle cell disease. When we look at private support, sickle cell was estimated to raise just shy of $500,000 in 2004. Cystic fibrosis in that same year raised $152 million in private charitable support. That's $500,000 compared to $152 million, a ratio of near 300 to 1. So the question for those of us concerned about that is not that one group has too much, but how do we raise the level received by the sickle cell population? And this question of inequity goes beyond funding, but also looks at the structure of the healthcare system itself. In 2009, authors from the CDC and the Health Resources Services Administration wrote, "There is uneven availability and utilization of multidisciplinary specialty clinics for different genetic diseases. For two disorders, hemophilia and cystic fibrosis, effective national networks of specialty clinics exist and reach large proportions of the target population. For other disorders, notably sickle cell disease, fewer such centers are available, centers are less likely to be networked, and centers are used less widely." They go on to find and say that although sickle cell disease is more common than cystic fibrosis or hemophilia in the United States, only a minority of affected individuals in this country are seen at specialized sickle cell centers. Although newborn screening and comprehensive care have made it possible for the majority of patients to survive into adulthood, many adult patients lack access to adult specialists and continue to have inadequately satisfied or unmet needs. So now, what challenges or questions is raised for us today? Well, the few I want to point out to you are, in many respects, sickle cell disease can be seen as a poster condition for racial and ethnic inequities in health policy. Now, if that is true, then what priority ought sickle cell disease receive in comparison to other areas of health inequity in our society? And does the vastly disparate level of private funding for sickle cell disease compared to other conditions generate for government funding agencies any special moral obligations to try to step in and ameliorate that gap? I think it's an open question that we can discuss. Now, the last chapter I want to talk to you all about today is sickle cell disease and healthcare quality. And it's basically clinicians and patients are dissatisfied with the quality of pain management provided to sickle cell patients. My colleagues and I recently published a systematic review of the literature on barriers to sickle cell care, and we found a high level of evidence to suggest that negative healthcare provider attitudes towards sickle cell patients serve as a barrier to the receipt of appropriate pain management for the sickle cell population. And we found a moderate level of evidence to suggest that poor provider knowledge about sickle cell disease serves as a barrier to pain management for sickle cell. And those are the only two factors that kind of came out as significant in our analyses. In a survey of physicians about their thoughts on barriers to sickle cell care, 86% of doctors disagreed that the most reliable indicator of the existence and intensity of pain is the patient's self-report, even though we know that in pain medicine, the gold standard of pain assessment is the patient's self-report. And among the top 5 physician-reported barriers to optimal sickle cell pain management, these physicians said the number 1 barrier was lack of psychological support from the patient's family and the medical profession. They thought that the fear that the patient is a drug abuser is a barrier, as well as reluctance to prescribe opioids, a disbelief in the patient's report of pain severity, and inadequate patient-reported pain assessment tools. And again, these are physician level, or physician thoughts of what the barriers, top 5 barriers to sickle cell pain management are. Now, this is these physician perspectives. What about the perspectives of patients? Well, I could tell you, but instead what I'm going to do is show you a video that we've actually developed to try to both educate people about the barriers that sickle cell patients face when they try to seek treatment for their pain. And we're also using this video to see if we can use it to improve healthcare provider attitudes towards sickle cell patients. So we developed this video, and we're going around and we're testing to see whether it improves the attitudes as measured by different survey instruments of clinicians towards sickle cell patients. And ultimately, we want to see, does it not just improve attitudes, but does it translate into improved health outcomes as well? And so with that, let's cue up the video.
First presentation of sickle cell disease may be when they're 6 months old. They have swollen hands and swollen feet, and it's clear there's something bad going on. Those children are treated appropriately. They're given pain medications. Everyone wants to do everything they can to help the baby. As you grow older, you have less of those manifestations. So you can present with crisis, and there is no objective measure that they're having a painful event. And so they suffer needlessly because no one actually believes that they're in pain. It's excruciatingly painful. There was actually a recent article published that sort of tried to capture what it's like to live with this disease on a daily basis. And 30% of the patients that were studied had pain 95% of days. But they didn't see care. They saw care for like less than 20% of those days because they know they're probably not going to get the care they need. And the other is that they've learned to cope with a lot of pain on a daily basis. One of the reasons I opened this infusion clinic is because I got tired of hearing how I presented to such and such place and they didn't believe me, or they made me wait for hours and they didn't really treat me with what I knew would make me feel better.
Right now, it's just mainly my wrist and the lower part of my back. The pain is like a 7 out of 10 scale.
When I go to the emergency room, there's a bit of a stigma where they don't want to see, it seems like they don't want to see you straight away. And I see a doctor that's not willing to give me the typical medicine amount of medicine that will help me get out of pain. It's emotionally frustrating, and then deal with the stress of that on top of the pain already. It just makes it worse.
How's your pain level?
Still a 7.
Once a patient has experienced 100 times over negative provider attitudes, you can imagine how they're going to feel when they present. And of course, then the provider now has more attitude because the patient has attitude, and so it becomes this circle and cycle of events which really leads to poor patient outcomes, and patients don't get what they need. Let me take a quick listen to you.
If I didn't have pain, like literally on a daily basis, it would probably bother someone that, you know, that doesn't normally experience it, but my tolerance for pain is so high, it's, you know, and I can't take like regular Tylenol or Advil or, you know, the over-the-counter medications. Those don't work. Yeah, it takes 5 to 6 milligrams of Dilaudid or morphine or both to get the pain under control, but that's what I need to get better. Whereas if I were at a facility that, you know, I visited for the first time, I'm a little reluctant to communicate that to them because I feel like they're judging me.
It used to be taught, and you can still find it in places, that if a patient tells you what dose of narcotic they need to treat their pain, that was a sign of addiction.
It's not even the verbal communication, it's the nonverbal communication that really gets under my skin, because, you know, you get this look and this tone like, okay, you've already had enough medicine, so I'm not giving you any more. Or, you know, you have to have felt something. That's the worst. When I hear, you have to have felt that. You have to, and I'm like, no, if I did, I wouldn't be buzzing you every 10 minutes telling you I'm in pain.
The last thing you want to do is to piss off one of the medical staff because you have to rely on them for care. And with a young family, I can't afford to be there around the clock.
I feel fortunate that I have children who see what I go through every day. My oldest son, Dorian, he'll come in and plug in my heating pad, or they'll all sit around in the bed with me until my husband gets home. When I'm in the hospital, I spend my entire time looking at the clock to make sure that I'm getting my medicine on time. I can't rest. I can't, you know, I just have to make sure that after 2.5 hours, I need to start buzzing the nurse, because otherwise I won't get my medicine on time. I feel like it makes me look like that's all that I'm there for.
They, you know, don't always know if, you know, you're telling the truth, or if you're just there for whatever reasons that they might suspect.
What do they suspect?
Sometimes drug seeking, or that, you know, you're exaggerating the symptoms for just the pain meds and not because you're actually in pain.
You can't tell them anything because they're the doctors. But I understand what is the point in asking me my history of what works best for me if you're gonna do what you want anyway and you're still not listening to me.
I'll go through extra measures of making sure that, this is weird, but making sure that I'm dressed professionally before I go to the hospital, or not go in like sweats and, in my socks, because I don't feel like I'm being taken seriously.
It's just a remarkable thing, that I have to call ahead of time and say, so-and-so is coming in and they're a professional whatever, so therefore we're going to believe them, whereas, this disease causes a lot of disability, and so a lot of my patients are unable to work. And so I can't call up and say, oh, they're, doctor, lawyer, whatever they are, to get them the kind of care they need. When you're sitting in an emergency room with the patient sitting across from you, what do you care if they're drug seeking? I mean, it's not your responsibility to make sure that the patient is not drug seeking. Yes, you shouldn't send them home with 2 months worth of narcotic scripts. That's not your role in that setting. But you can treat the patient for their pain and manage their pain, and then refer them to someone who can take over the responsibility of managing their narcotics and see whether or not there might be an issue with their narcotic use. But in the emergency room setting, what difference does it make? If you're the person trying to make that decision, you need to be wrong and say, oh, well, here's a patient who's in horrible pain, and I didn't treat them because I didn't believe it. I don't want to be the provider who's wrong in making that decision, because if I'm wrong and the patient actually is in a lot of pain, I'm making that patient suffer, which is not why I decided to become a doctor in the first place. So.
If we can stop it right there. So the 100-year history of sickle cell disease is full of a number of fascinating tales that I couldn't even go into just for the sake of time, and there's more than one person can present in one presentation. So I tried to bring out just 3 chapters in our history. It's characterization as a black disease, the kind of inequities or apparent inequities that we see at the health policy level, and the issues of quality health care and pain management that sickle cell patients seek as 3 of the more significant, in my view, health challenges that the sickle cell population has faced throughout its 100-year history, and that we continue to face and struggle with today. And so I want to thank you all for your attention in this presentation, and I hope it's been successful in raising awareness, and I look forward to our discussion. Thank you very much.
In order to authentically show up as healer, I must evolve through my own process. I have the choice to transcend. It all comes full circle. I suffer, I heal, and then I give. The giving expands me. The more I have to heal, the more I give to heal others. Dr. Ariana Scholes Douglas. Dr. Haywood, it is with sincere gratitude that I receive your message and the healing and the incredible opportunity for healing that your message brings. When I reflect on this presentation today, I think I was most struck by the 3 chapters of our history. The racialization, that was very striking to me. Not that the racialization occurs, I have a personal history of understanding that happens, but what was striking to me were the dates. 1963, 1971, 2008, where these racialization views are still very prevalent. That was very striking to me. Excuse me. Also in inequities of healthcare policy and in the structure of the healthcare system, the inequities in funding, and just to see the numbers, the 40-to-1 funding inequity also was very striking to me. Physicians and other healthcare providers, we often find comfort and compassion in our ability to see children as blameless. And enough advances in medical care, as you've seen in the lecture today, have come so that more children with sickle cell disease are surviving into adulthood. We heard the life expectancies of 42 for men and 48 years for women. The unfortunate thing is that sometimes in their adult states, those same children may not be as fortunate in their gracious and blameless perceptions of their caretakers. And sometimes they may be subject to the frustration and the blame of the very people there to help them. I really appreciate also the video that was shared because it essentially captures my comments and my own personal observations, We've heard about the complications of sickle cell disease, and often the emergency department is a place where those patients present. In our setting, it's easy to summarize their treatment and management in 4 categories: assessment, diagnostic testing, treatment, and disposition. Now, in my own observations and my practice of 14 years in the emergency department here, is that I would say that we are quite prepared to rapidly identify and intervene on those complications that meet the physician's perception of disease. Things like dactylitis that we saw in the video, the babies who come in with the sausage-looking fingers and the pain. And we immediately recognize that this is a child with sickle cell, and because they have this, and if they're less than 1 year old, then they've got a 2.5% greater likelihood of having severe problems when they're older as adults. Other things like acute chest syndrome, splenic sequestration, priapism, pneumonia, sepsis, osteomyelitis, we're there, we're good, because that represents our perception of disease. The observation of caution we've already seen in the video is that when the sickle cell disease patient presents and they say, this drug works, or I usually receive this amount, my observation is that physicians also, they go through this mental conditioning where a flag goes up and that flag says drug seeking. And unconsciously, they enter into this state of resistance. And in that state of resistance, they lose their ability to see and recognize disease. I would just say this. In the absence of a pre-approved protocol that the patient and the patient's primary care physician have worked out, there's no cause or justification for you not to take heed to what the patient tells you. Giving a different drug has not been shown to effectively relieve pain, and the patient often ends up receiving the drug they requested in a significantly delayed fashion. This is an unnecessary phenomenon. One study in Chicago looked at collaborative models to improve pain management in sickle cell, and it clearly showed delays in number 1, the time to receiving pain medicine, and number 2, that patients were being discharged with higher pain levels than they believed to be acceptable. In the video, we also heard that there are very few findings, physical findings, that we can latch on to that speak to or address the amount of pain that is occurring in a pain crisis. There's no lab study, no pain level blood test that we can draw. And the single most reliable measure in every instance remains the patient's self-report. It's important that we document the pain scores and address those to modify the treatment and management of the patient's pain. What I really also appreciated in the video is one other aspect of something that I thought was important, and it is like the standardization of care, just standard practices and protocols that help deal with this. Now, I may be mistaken, but the infusion clinic that I saw in the video seems to represent the concept that I've read about day hospitals for sickle cell patients. And these are outpatient facilities that are designed specifically for the management and treatment of sickle cell pain vaso-occlusive crisis. They're also very poised to recognize the severe complications that require hospitalization, but they're very effective in their protocols for managing pain. They've been clearly shown to reduce hospital admission and the cost for caring for patients with vaso-occlusive crisis. To the best of my knowledge, in the 14 years that I've been here, we do not have a day hospital for sickle cell patients here. They all do come through the emergency department. But seeing this video and reflecting on what has been presented here today, it would certainly be great if we could create a policy within our emergency department that establishes some pretty solid protocols for the rapid diagnosis and treatment and management of the pain and rapid admission into the hospital. I came to this meeting today with a little bit of apprehension, being an emergency physician, having worked here for 14 years, and I very cautiously approached Dr. Haywood, and I said, in your time here, did you ever have to go to the emergency department? And his response was, he talked to me about the great advances in therapy and that the fact that he was taking hydroxyurea, and with that simple intervention, it only required one visit to the hospital. And he reported that I was in the emergency department so briefly, I don't even remember my experience there. With that, I certainly breathed a sigh of relief. But I cannot say in the observations that I had that all of our patients can have that same testimony. Basically, our goal, our common practice in the emergency department is rapid relief of pain. We try to do that. But I'm the first to admit that we probably fall short. And when we make efforts to admit our sickle cell patients' pain, sometimes the admitting physicians who are on the other end receiving these patients, there's a resistance to admitting a patient just for pain. So I think that we have to constantly remind ourselves and reinforce what the speaker in the video said, that we are here to help, we are here to heal. Hippocrates, the author of the oath that we took as physicians, said that healing is a matter of time, but sometimes it's a matter of opportunity. I hope that we all, as healthcare providers of sickle cell patients, can be sure that we are doing our best to present every opportunity for healing to our patients. In order to show up authentically as a healer, I must evolve through my own process. I have the choice to transcend. It all comes full circle. I suffer, I am healed, and I give. The giving expands me. The more I have to heal, the more I give to others. Again, Dr. Haywood, I thank you for your incredible gift for reaffirming our capacity for healing.
Well, I thank you both for a very powerful presentation, and now the floor is open. See a hand over here already. I can step over you, Ken. If you'd say your name.
I'm Dan Moeller, retired hematologist on the faculty here, and I enjoyed your presentation. We didn't get the time to say much about sickle cell trait, because when you just get the gene from one parent, but there's a huge group of people with sickle cell trait. And one of the big controversy now is coming up, particularly with athletes who have just the trait, and whether that's causing health problems when they overexert. And I guess the NCCA is thinking about having everybody tested, and I wondered what your feeling was about testing athletes for sickle cell trait.
Sure. So for those who may not be familiar, the NCAA, which is in this country, the governing body of college athletics, because of a number of deaths among college athletes, particularly college football players over recent years, where the only so-called cause of death that's been found has been that the athlete had sickle cell trait. There's this concern that, well, sickle cell trait contributes to something called sudden death among athletes. And so the NCAA just this year passed a policy which now mandates all of Division I college athletes must go through testing for sickle cell trait unless they can either, one, show the results of a prior test that they've had and share the results with the school, or two, sign a waiver which says, I don't want to be tested, but I'm also going to release the school from any liability should something happen to me. And so that's the policy as it is right now. And I'll be honest with you, I certainly understand our need to try to do something to eliminate the deaths that have occurred. I am not convinced that this particular screening policy, as has been passed, is the appropriate way to go. I have a number of concerns about the ethics and the implications of that policy. The military has shown that if you enact rigorous protocols for hydration and rigorous protocols to eliminate heat-related illness for all persons in the military, they found that any disparity that existed between sickle cell trait and those without trait, it went away. And so that was a program that did not require any kind of targeting of the person's sickle cell trait. And so one question for the NCAA is, why do you feel that you must actually target the individual with sickle cell trait as opposed to trying some other protocol, which admittedly may change the culture of college athletics, but the question one might have is, would that be a bad thing? So.
I was struck in each of you talking, this is because I'm a pediatrician, you know, about the difference in care for children with sickle cell disease and adults with sickle cell disease. And of course, sickle cell, like cystic fibrosis and like certain forms of congenital heart disease, didn't used to be something that adult physicians saw. So from life expectancies. And I'm interested, Carlton, in your experience of that, of shifting from pediatric doctors to adult doctors, but also what you think might be necessary for the education from either of you, about the education for internists, for example, for taking care of persons who grew up with this.
So I was very fortunate in my own personal experience. In high school, so it wasn't until high school that I saw my first pediatric hematologist who had a special interest in sickle cell disease. And so he taught me how to be an advocate for my condition and for myself. So that was in high school. Then I was fortunate I was able to come here to University of Virginia, which had a pediatric hematologist, Dr. Peter Waldron, also an expert in sickle cell disease, who provided excellent care for me. And then when I graduated here, I moved to Johns Hopkins, which just so happened to have an adult sickle cell specialty center. And so my experience, unfortunately, while it was great for me, that is not typical experience for most people. Most people, while there is more availability of comprehensive care for pediatric patients, as we said, that is lacking for adult patients. And so one bit of education that I try to do is I try to talk to medical staff, house staff or residents throughout the various processes of their medical training to try to get them to see a more personal side of the sickle cell patient. And part of our goal with the video is, I think that many clinicians, they only see us sickle cell patients when we're at our worst, when we're in so much tremendous pain, we're at our worst. And they don't see that, just like other patients, we are people who have the same kind of goals and desires of life as everyone else. And if you only see us at our worst, you see a very skewed view of us. And so part of our goal in making this video was to try to see a broader aspect of the person, not the patient, but the person with sickle cell disease, and try to help people understand, as educational, try to help people understand that aspect of it as well. So that's the approach that we try to take.
Bob Chevalier, Pediatrics. I'm curious as to what is the perception to this disorder in other developed countries, Europe, for example. Is this an American phenomenon, the degree of racial profiling and all that goes into this history?
That is a great question. While the issues of race per se, you'll find differences in different countries. When you actually look at the literature that asks patients to describe their experiences of care, most of the literature that's not from the U.S. comes from the United Kingdom, and the language that the patients in both populations use is strikingly similar. Excuse me. If you look at the qualitative research that's published, patients in both countries, they tend to say the same things. Clinicians don't seem to listen to me. They don't seem to try to take account my own experience with Lyme disease. I was at a conference in New York last year. I got sick, had to go to the hospital, so I was in a place that was strange to me. And the hematologist there said, well, I have 30 years of experience in taking care of sickle cell patients. Well, I have 33 years of experience taking care of sickle cell in me. And so we need to work together instead of you dictating to me what's going to happen. So we had a very contingent relationship. And you see that in literature in the US and UK, you see surprisingly the same language. They're not listening to me. They don't believe me when I say I'm in pain. And so it's very striking. We're actually right now about to start a study where we compare a sickle cell data set and a UK data set, some more objective measures of quality care, to see if we can find what kind of differences or similarities they may be in those other aspects.
We're out of time, I'm sorry, and they cut this off because of the video. But Dr. Haywood and Dr. Ross will be down here for a bit for other questions. I'm sorry to cut you off. I also want to invite you to come to Medical Center Hour next week, which will be not here, but in the School of Nursing and the McLeod Hall in Fenwick Auditorium. It's the Vice Memorial Lecture sponsored by the School of Nursing. The speaker is Professor Cinda Rushton from the Berman Institute of Bioethics at Johns Hopkins, as it happens, speaking on trust and betrayal. Please join me in thanking Dr. Haywood.